morning, good afternoon, and good evening to all the speakers, chair, and the wonderful audiences in different parts of the world, and welcome to the ACNS webinars. The speaker for the first section of today is our honorable guest from Singapore, Professor Tien. Professor Cheong is a consultant neurosurgeon and holds a key leadership role as the co-director of the Neurointensive Care Unit and the director of Head Injury and Trauma Program at the National Neuroscience Institute in Singapore. He specialized in neurovascular surgery, including cerebrovascularization procedures such as the ECIC bypass and carotid endarterectomy, as well as neural intervention and minimally invasive surgery for intracranial hemorrhage. His research interest is focused on neuroprotection in intracranial hemorrhage, serving as a principal investigator of the SCAT trial. He's also a co-author on multiple peer-reviewed publications spanning general neurosurgery, neurotrauma, and neurovascular conditions. And we are extremely honored to have him today with us as a speaker for our webinars. And today he will be talking about beyond clipping-versus-coiling, aneurysm decision-making in the modern era. And the speaker for our second session of today is our very honorable guest from China, Professor Gan Chao. Professor Chao is an attending physician in the Department of Neurosurgery at Tongji Hospital. He graduated from the 8-year clinical medicine program at Tongji Medical College, Guangzhou University of Science and Technology in 2013, and he did his postdoctoral fellowship in Essen University Hospital in Germany. He is primarily engaged in clinical practice and research in cerebrovascular diseases and traumatic brain injury. He participated in 3 National Science Foundation of China projects and published over 20 SCI papers, including 7 as the first corresponding author. And we are extremely honored to have him today with us to be the speaker at our webinars. And he will be talking about the application of keyhole surgery for anterior circulation aneurysms. The chair for the first session of the day is vastly experienced eminent faculty from India, Professor Meng. Professor Meng is a consultant neurosurgeon at the SP Medford Hospital, Trivandrum, and Cerebrovascular Institute of Medical Sciences in Kanyakumari in India. He was the former head and professor of the neurosurgery at KMC Manipur and SCTIMST Trivandrum. He's the pioneer in epilepsy surgery and cerebrovascularization in India. He has trained over 50 neurosurgery residents, and he's the leading invited faculty to various conferences and workshops worldwide. He's the current editor of the chief of the National Neurosurgery Journal of India, the Neurology India. He has also a vast number of publications in leading neurosurgery journals around the world, and we are extremely grateful to him for accepting our invitation to chair the section of Professor Tien. The chair of our second session today is our very honored faculty from the UAE, Professor Florian Rosa. Professor Rosa is the chair of the Neurological Institute in the Cerebrovascular Clinic, Abu Dhabi. He was a previous vice chair and the chief of the staff at the Department of Neurosurgery at the University of Tübingen in Germany. He completed his residency in the prestigious Department of Neurosurgery at Hannover, Germany, and he holds the position of the full professor of the neurosurgery at the Faculty of Medicine at the Eberhard Karls University of Tübingen in Germany. He serves as a professor of surgery in the Cleveland Clinic Lerner College of Medicine in the Case Western Reserve University, Ohio in USA. He's also adjunct professor at the Biomedical Engineering Faculty in the Khalifa University in Abu Dhabi. He's the editor-in-chief of the Journal Clinical Neurology and Neurosurgery and the associate editor for World Neurosurgery. He has over 107 peer-reviewed articles and 18 book chapters, meaning as the first or senior author. And we are extremely honored and grateful to him for chairing the second session of today's webinar. On behalf of the Educational Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of the ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shibin for broadcasting the webinar on the WeChat channel. And Dr. Liu Bun Singh from Malaysia is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Meng. Professor Meng, please.
Thank you, Ben. Thank you, ACNS, for this opportunity. Good afternoon, good evening, and good morning to all our viewers. The debate between coiling and clipping never seems to end, and with the advancements in endovascular techniques, interventional technique seems to be the standard of care for most aneurysm procedures all over the world. Yet there are a few select cases where surgery is indicated, but the decision making regarding surgery always remains complex. Aneurysm management is always a team effort, but there always exists this dilemma because the endovascular surgeon always feels the coiling, and now with so many options available like simple coiling, stent assisted coiling, or flow diverters, almost all aneurysms can be managed endovascularly. But all vascular surgeons and stroke specialists would agree that there is a select group of aneurysms which always require surgical techniques, the complex ones. And to give us more clarity on this particular topic, we have with us, fortunately, one of the most prominent, popular, renowned neurovascular surgeons, Professor Cheong from Singapore, from NNI Singapore. Dr. Cheong, please.
Thank you very much. Thank you very much, ACNS, for giving me the opportunity to share my experience and also exchange idea with all the experts in the world. As what Professor Menon mentioned, this debate is really never ending. Hopefully, I'm able to share some of my insights on how we can resolve this situation. So I would like to start with a little historical perspective to show how we got to where we are. The very first aneurysm was clipped in 1938 by Sir Walter Dandy, but really it was Professor Yasagil who revolutionized microsurgery and made microsurgical treatment of aneurysm into a safe and reliable treatment options. Of course, we all know what happened next. While surgical ablation remained the gold standard for a long time, the invention of coils and also the publication of ISAT in 2003 showing a superiority of endovascular treatment in acute SAH patient, and that really started the explosion of endovascular field and also the beginning of the clip versus coil debate. But we all know that endovascular treatment is not without its problems. And essentially, while advancement in the endovascular therapies made aneurysm treatment safer, durability was a real problem. Especially in the BRED study, there was up to 20% retreatment rates in the endovascular group. So of course, the endovascular side responded with an explosion of devices and also techniques. There were new coil designs, there were intrasaccular devices, there were stents, there were flow diverters, there were neck bridging devices and all that. So right now we are in a situation where we have a lot of devices, a lot of techniques, also very mixed data, a lot of marketing, and also a lot of noise. So how do we actually select the best treatment among the multiple acceptable options? And also which innovations truly improve outcomes? And how do we avoid being distracted by all the noise and all the hype surrounding all these new techniques and new devices and new innovations? So what really is happening now? Innovation has transformed aneurysm treatment from being a tactical challenge in the era of Yasagil and the old giants to now a decision-making challenge. So how do we resolve this? I would like to then go back to the principles of treating an aneurysm. We all know that aneurysm is essentially a disease in the vessel wall caused by an interplay between the vessel wall biology and also hemodynamic factors. And we all know that to cure an aneurysm, you have to close the defect, or you can sacrifice the parent artery, or you can resolve the hemodynamic changes in the parent artery and therefore promote healing of the defect. But can evidence actually guide us? So there are many studies studying endovascular versus microsurgery. The prominent one include ISAT and BRED. With ISAT, we have to remember that the inclusion criteria are aneurysms that are deemed equivocal for surgery and coiling, and many have argued that since the days of ISAT, endovascular have improved with new devices and all that. BRED study is actually more inclusive, and actually BRED study showed that there was no difference in long-term outcome in terms of endovascular or surgical treatment. ISAT 2 again is a newer study which looked at all non-ISET aneurysms, which means aneurysms that were excluded from the ISET trial, again, it really failed to show the difference in long-term outcomes in both arms. How about new endovascular devices? So this is all the studies regarding one of the new devices, the web device. Again, the same problem exists. The problem with complete low degree of complete occlusion, high retreatment rates, and all that. And the problem persists even at 5 years follow-up. How about flow diverters? So flow diverters is really the only endovascular device with no documented recurrence after a complete occlusion has occurred. But again, we need to note that it only has that if there's complete occlusion, which means that if there are a huge group of aneurysms that actually, even despite a adequate flow diverter placement, there was no occlusion or delayed occlusion, particularly in large aneurysms, aneurysms with incorporated branches, and also in fusiform aneurysms. Yeah. So in summary, we know that for long-term durability, clipping is probably still better. Flow diverter, only if the aneurysm is occluded, will probably have very good durability. For short-term functional outcomes, especially for aneurysms that were included in the ISET trial, for example, those that had narrow necks, that can be treated with simple coiling, they show better functional outcomes. But outside of those, really, there's no conclusive evidence that either microsurgery or endovascular treatment actually have an advantage in the long-term outcomes. Yep. So I'll run through some of the examples of challenging aneurysms and the decision-making process that I go through. So I'll start with this aneurysm. Basically, this is an aneurysm with an eloquent branch. If you look at it closely, this is an anterior choroidal aneurysm. The anterior choroidal artery actually branches from the neck of the aneurysm. This aneurysm has a narrow neck, and probably with this aneurysm, a simple coiling will probably suffice, while that can occlude the aneurysm at the same time preserve the anterior choroidal artery. This aneurysm, however, is a bit different. So this is a 40-year-old female, a young patient, has a WFNS grade 1 aneurysm. In this patient, the durability of treatment should be a consideration, because also, if you look at the aneurysm here, there is a relative wide neck, and the anterior choroidal probably take off at this point. So with simple coiling alone, it will be very difficult to coil off this aneurysm without affecting or even occluding the anterior choroidal aneurysm, and anterior choroidal artery. So this patient, I've decided to perform surgery. So this is the intraoperative view. You can see this is the optic nerve. This is the internal carotid artery, and this is the aneurysm. You can see the anterior choroidal artery actually peaking at the side of the wall of aneurysm. You can imagine if I start putting coils here, the coil will definitely occlude the anterior choroidal artery, causing ischemic symptoms. So with surgery, this artery can actually be visualized properly, and a clip can be placed avoiding this artery. So this patient actually recovered with minimal to no neurological deficits. Yeah. So another example, this is a 45-year-old female patient, WFNS grade 1. She has two aneurysms in the ICA, a PCOM aneurysm and an anterior choroidal aneurysm. Similarly, the anterior choroidal artery arises from the neck of the aneurysm. Again, if we coil this aneurysm, very likely we'll probably occlude the anterior choroidal artery. The difference between the previous case and this case is, if we perform surgery for this case, the takeoff of the anterior choroidal artery is very likely on the blind side of our surgical approach. So visualization will be important. So how do we solve this problem? So with this, I actually decided to perform MEP and SSCP monitoring because I will have this problem. After clipping the PCOM aneurysm, this is the anterior choroidal aneurysm, and the anterior choroidal artery probably arises from the back of it, and I can't see it. So in order to avoid it, I actually just place a tentative clip, run continuous MEP and SSCP with a view to readjust if there's a drop in MEP. So my experience with neuromonitoring for this sort of cases, I've done in total of about 8 patients with SSCP and MEP monitoring for anterior choroidal aneurysm clippings. In 7 patients, there was no drop in SSCP and MEP, and and in those group of patients, there was no new deficits post-operatively. In one patient, there was an intraoperative drop in MEP and SSEP, and in that patient, despite trying different clip configurations, there was no improvement in MEP signals. This was a giant aneurysm in the ICA, and very likely the artery was probably injured during the dissection of the aneurysm, and this patient suffered a anterior corridor infarct. So in my view, this method of monitoring is actually quite reliable and produces consistent result if the anterior corridor artery is affected during surgery. Yeah. So how about wide neck bifurcation aneurysm? This is another group of aneurysm which can be challenging to treat. So what is the problem with a wide neck bifurcation aneurysm? Essentially, in this aneurysm, there are two efferent branches, and because of the wide neck, there's a large open surface area of the aneurysm neck. With coiling itself, it's probably difficult to retain a coil, and also there's probably very high thromboembolic risk. The recurrence rate is also not low due to the water hammer effect. Yeah. For these aneurysms, there are actually multiple treatment options, but very importantly, in this group of aneurysms, we need to achieve a very good, almost perfect neck reconstruction in order to lower the risk of recurrence and also maintain patency to the efferent vessels. Yeah. So let's go through some examples. So for example, this is a very elderly patient with WFNS grade 2 SAH. Durability is probably not a huge concern here because the aim here is really to use the most minimally invasive method to prevent re-rupture in a very elderly patient. There's option for stent-assisted coiling. However, in this patient, acutely ruptured patient, putting stents in would probably increase thromboembolic risk, and also the patient will have been placed on dual antiplatelet therapy. How about balloon-assisted coiling? Clipping is definitely out of the question. So for this case, actually, I've decided to use a target tetra detachable coil. This is sort of a new coil design, and it's designed for relatively wide neck aneurysm. They have increased shape stability and therefore less likely to prolapse into the parent artery. So this is how the coil works. So it actually has two parts to the coil. We have a first part which is more a tetrahedral shape, and the second part which is a helical, softer shape that fills up the meat of the coil so that it actually enhances stability of the coil. So thankfully for this patient, this method alone managed to achieve quite a good occlusion of the aneurysm, and the patient actually recovered quite well after the procedure. Yeah. For young patients with MCA aneurysm such as this, I think the choice is still surgery because the approach is relatively straightforward and also with good durability to prevent recurrence. But this sort of aneurysm is another different story. This is a 59-year-old female with a high-grade SAH and also hydrocephalus. EVD was inserted and the angiogram actually showed a basilar tip aneurysm, relatively wide neck. So if you look at this aneurysm, it's very wide neck, probably involving one of the PCAs here. Coiling alone would not work because with the large neck here, coil will likely prolapse and occlude one of the PCA branches. If we were to treat it with endovascular treatment, we probably need either a Y stenting, stent-assisted coiling, or other newer devices. Of course, clipping is an option, but clipping generally are more complex in the posterior circulation, and therefore for this case, I actually decided to use a neck bridging device. So this is a P-conus device that actually is designed for aneurysms such as this. So it has a petal-shaped leaflets at the tip that actually is to support a coil in at the neck of the aneurysm. It has a stent-like structure that actually sits in the parent artery to support this, to anchor this petal so that coiling can be performed at the aneurysm. So with this sort of approach, you'll need a bilateral vertebral artery approach. One of the microcatheter is used to cannulate the aneurysm, and the other microcatheter is used to deploy the stent at the neck of the aneurysm, and subsequently the aneurysm can be coiled. So the key with using this device is that the crown of the device, the so-called the petal, must be placed very flush to the neck to reduce dead space, because we need to achieve a very good neck reconstruction in order to prevent recurrence. So this maneuver has to be done at the end after we open up the petal of this device. It should be pulled back so that it's snugged to the neck before the device is fully deployed. And after that, it can be coiled. The aneurysm can be coiled and can be packed tightly. Yeah. So for this case, this is the end result of the coiling. Yeah. So the P-conus device actually sits at the neck here like a champagne a glass, and coils can be packed at the dome of the aneurysms. Yeah. So this is the other group of aneurysms that are potentially challenging to treat, the large and the giant aneurysms. Large aneurysms are defined as aneurysms that's larger than 10 millimeter, while giant aneurysms are defined as aneurysm larger than 25 millimeter. Generally, the pathology is due to either dissecting process or circular aneurysms, and this group are not actually included in the ISAT population, and therefore the treatment of this aneurysm, we know that it remains a challenge. Yeah. So why is it a problem? So one of the one of the option of treatment of giant aneurysm is using a flow diverter. So the problem with that is this is a very interesting study where they showed the histological changes in the giant aneurysm after placing a flow diverter. So they found that in the giant fusiform aneurysm, when the flow diverter is not opposed to the wall of the aneurysm, endothelialization actually fails to happen most of the time. So, for example, this is the red one here is a visual representation of the aneurysm. This is the fusiform part, and this is the normal artery. So if you place a flow diverter across here, only the parts labeled in green are actually well opposed to the wall of the vessel. So endothelialization probably can happen here, but across the gap of the aneurysm, the endothelialization probably will be delayed or slow to form. And when that happens, there is always a risk of re-rupture as long as the healing doesn't occur, and also there's risk of thrombosis and also persistent mass effect. Another issue is that in giant aneurysms in the cavernous sinus, the enlarging ICA aneurysm in the confined space of the cavernous sinus can actually compress on the parent artery, causing luminal stenosis. This is what we term matricidal aneurysm. I'll show you some examples. So this is the first example of a giant aneurysm. So this giant aneurysm, if you look closely, the distal and the proximal artery does not appear to be compressed. You can see the distal part here and the proximal part here is fully opened. The neck of the aneurysm seems to be incorporated at least half of it of the parent artery. So this part near the neck there is probably slightly fusiformed. If I perform a flow diverter here, I can probably get good wall opposition, distal part here and also here. In the middle part, probably I can oppose the flow diverter to this part of the wall, but there'll still be some open part over here. But because the neck is this gap is relatively short, this flow diverter will probably work with this aneurysm after I put some coils in there. The issue with this case is actually the access. So because to get to the distal part of the artery, we'll probably have to use a round-the-world technique. So this is what we did. So using a microcatheter, the microcatheter actually goes around the aneurysm one time, and then before I'm able to cannulate the distal artery. After that, I anchored the microcatheter at the distal part of the artery. Using that as an anchor, I'm able to straighten out the microcatheter. For additional support, I actually rail the intermediate catheter across the neck of the aneurysm, and then with that, deploy the flow diverter across it. And this is the end result. The flow diverter is placed across the aneurysm, and aneurysm then after that coiled tightly. So with this aneurysm, a flow diverter will probably work. Yeah. But how about this one? So this aneurysm, it's not a giant aneurysm. It's a 10 millimeter right ICA supracranial aneurysm. It was rapidly increasing in size. The issue is that in this part of the aneurysm, the ICA is quite ectatic. It measures close to 6 millimeters here. So in our country, at least, we don't really have a flow diverter that can expand up to 6 millimeter. So a flow diverter in this case probably would not be a good idea because I'm unable to get good wall opposition across this entire neck of the aneurysm. Yeah, so for this case, I actually decided to perform surgery. So the technique for my strategy for this is that because it's very close to the this is ophthalmic artery, proximal control will be a problem. I've decided to open up the neck for proximal control at the cervical ICA. Of course, if anyone has a hybrid OT, that proximal control can be performed with balloon occlusion at the cervical ICA. And after that, for this case, I will have to probably open the falciform ligament and perform a partial crinoidectomy to expose the ICA proximally, and then perform clip reconstruction under proximal clamping to deflate the aneurysm. So this is the intraoperative view. This is the large giant aneurysm, the large aneurysm. This is the A1. As you can see, the aneurysm is compressed and pushing the optic nerve to the side. This is the optic canal and the anterior clinoid. This is the distal part of the ICA. Yeah. So with this, the only exposure I need in this is actually to open up the falciform ligament over here, and also to drill off the optic canal and also the anterior clinoid over here. I don't really need to do a complete anterior clinoidectomy, just enough so that I can see the normal non-disease part of the ICA and then perform clip reconstruction. So this is the surgical video. Yep. So I just need to drill off. This is the direction of the optic canal. So after drilling off that and cutting off the falciform ligament around this region, the proximal part, the normal part of the ICA can be exposed. Yeah. So after proximal control and a tentative clip to deflate the dome of the aneurysm, I can clearly see the distal part of the ICA and also the proximal normal part, and finally perform a clip reconstruction to reconstruct the length of the ICA here. Yep. So this is the end result. The aneurysm, the ICA is properly reconstructed. So how about this case? So this is a 31-year-old male, presented with a 6th nerve palsy. There's a giant left cavernous ICA aneurysm. Unfortunately, this patient also has a chronic occlusion of the left ICA. Very likely, the patient probably has a mirror aneurysm, and the other aneurysm was probably thrombosed, and therefore causing an occlusion of the contralateral ICA. So actually, if you look at it, this ICA with this aneurysm is actually supplying the patient's right hemisphere, and also at the same time bilateral ACA territories. The left MCA territory is supplied by is reconstituted by the posterior communicating artery via the vertebral artery. So for this case, with such a long fusiform segment, flow diverter would not be a good choice, because again, I cannot achieve good wall opposition across here. And also, if you look at this part of the artery is actually compressed by the aneurysm. So the radial force of the flow diverter would probably be challenging to open up this. The flow diverter would probably not open in this segment of the artery. So again, flow diverter is not a good option for this case. So that really leaves us with trapping of the aneurysm. But how then do I replace the flow for the entire right MCA territory and also the bilateral ACA territory? So for this case, I've decided to perform my flow replacement strategy, essentially a external carotid to M2 bypass with a radial artery graft, and followed by a double barrel STA to M4 bypass to hopefully supply enough flow to that part of the hemisphere, and also bilateral ACA territories. After that, I'll perform trapping of the aneurysm between the cervical ICA and intracranial ICA. Yeah. So this is essentially the radial artery joining the M2 branch over here. This is the Ceong fissure. This is the double barrel STA bypass. One branch, the frontal branch of the STA is connected to M4 branch at the temporal side of the Ceong fissure, while the parietal branch of the STA is connected to a M4 branch in the frontal side of the Ceong fissure. Yeah. So again, for the bypass, is the usual technique where you anchor the heel and the toe stitch first. The important things here is essentially to ensure that the intima, the vessels are stitched together from intima to intima. So that's essentially the important step over here. So that's the heel stitch, sorry, toe stitch, and is the needle really have to be passed through the full thickness of the vessel wall. Yeah, and generally I like to perform I like to use a loop technique, which means that I actually loop through the sutures first, because that would keep the vessel open, and because of that I'm able to visualize the intima properly, and after that I actually then tie the sutures individually. Yeah, so this is the end result. You can see the radial artery graft supplying the MCA territory here, and also the bilateral ACA territory. It's of course supported by the double barrel STA-MC bypass over here. Yeah. Yeah, so this patient actually recovered quite well without any deficits. Yeah. Yeah. How about this other patient? This is a 60-year-old patient, giant left cavernous ICA aneurysm. Again, if you look at this angiogram, this large aneurysm actually compressed the distal part of the ICA over here, and also this proximal part of ICA is also compressed. Again, this case, you can even see this part of the ICA here being compressed against the bone in the cavernous sinus, causing a like a filling defect over here. Yeah. So with this case, flow diverter would never work because a flow diverter would never open in this condition. Yeah. So again, this case will probably need a trapping and a bypass because the patient failed occlusion test. Thankfully, this patient has an intact IC on the contralateral side. So for this case, I perform a high flow bypass using a radial artery graft connecting the external carotid artery to the M2 branch here. This is the ICG after the bypass showing filling of the vessels. And after ensuring that the vessels are all filling, in these patients I also usually do them under neuromonitoring, and ensuring that the neuromonitoring is intact. After that I place a final clip at the proximal at the intracranial ICA near the skull base, and also another clip at the cervical ICA, essentially trapping the aneurysm at both ends. Yeah. So this is a post-op angio showing good perfusion of the MCA territory. No aneurysms here. This is a 6 months CTA showing persistent perfusion of the left hemisphere via the radial artery graft. Yeah. So not all patients actually need a bypass. This is a 25-year-old male with a giant right ICA aneurysm. With cross compression test, there's actually very good cross flow across, and also this patient also passed balloon occlusion test. So with this patient, we just proceeded with parent artery sacrifice of the right ICK together with the aneurysm. This is the end result. There's very good cross flow. So the patient again recovered without any deficits. So essentially, putting it all together, modern aneurysm treatment actually offers more choice than ever before. Evidence again offers very limited guidance at times because each aneurysms are actually and patient is actually unique. The optimal treatment should actually not be defined by technique or specialty. There should be no dogma of an endovascular first or surgery approach. So this idea of weighing between endovascular options or surgical options should not really be the answer, but rather it should be disease-centric. The treatment should involve individualized care based on aneurysm morphology, aneurysm location, patient-specific considerations, as also available local expertise, choosing the simplest and safest and most durable options for every case. Yeah. So really the role of a modern neurovascular surgeon should be hybrid trained across both microsurgical and endovascular techniques, because they should be expert in both in simple and complex microsurgery, including high flow bypass, should have expertise in the full spectrum of endovascular treatment, practice within a centralized high volume neurovascular center, and also have a subspecialist practice. And because mastery of both treatment repertoires enable the selection of the simplest, safest, and most effective strategy for each patient, unconstrained by specialty or technique. Yeah. So finally, technology and skill expands our option, but again, judgment actually determines our patient outcome. Yeah, thank you very much.
Thank you, Professor Cheong, for an excellent presentation. Exquisite surgical skills as well as endovascular techniques and your choice of cases. So I guess there were different varieties. You had these anterior choroidal aneurysms with branches arising from the neck as well as the fundus of the aneurysm. And then you demonstrated the wide neck bifurcation aneurysms and how you chose the approach. Then the large, the basilar bifurcation aneurysm and your choice of technique in that. Then of course the large giant aneurysms, couple of cavernous segment aneurysms, and how you proceeded with coiling with anastomosis as well as trapping of the aneurysms. So just to set the ball rolling, can I start off with a couple of questions? And so,
Yes.
what in your personal experience and your personal series is your recurrence rate for coiling and for clipping?
I think for clipping, generally the recurrence rate is very low. For coiling, if the cases is selected appropriately, the recurrence rate can be as low as less than 10%. However, when making a wrong choice, actually, then the recurrence rate can be high. For example, for a wide neck aneurysm, if a neck reconstruction is not done properly, then generally in those cases, the recurrence rate is slightly higher.
Now, what is your institute policy? How often do you do check angiograms and surveillance for the aneurysm?
So we do MR for coiled aneurysms, we do MRA yearly for at least 10 years. For aneurysms that are clipped, usually we do a post-op CT angio, and also 1 in 1 year. And generally, if there's no other aneurysm to follow up, we can actually discharge the patient.
And what is your policy for coiled aneurysms which has rebled? Would you prefer surgery, or again it is customized? Is it
You mean recurrent?
a
Or yeah,
coiled recurrence, not unbled, a bled recurrence
yeah.
after
So
post coiling?
yeah, so generally, again, it should be individualized. So, for example, there are some cases where in acute setting, we know we didn't perform a good occlusion because you probably know that for that aneurysm, the best treatment would be a coiling plus a flow diverter, but you probably don't want to do a flow diverter in the acute setting. So, generally in those patients, we usually stage it. We do partial coiling and then a flow diverter later. But if they do rebleed in the interim, then definitely the option of would be adding a flow diverter. But of course, if the aneurysm is coiled and then it recurred, you again have to look at the morphology of the recurrence. So if the recurrence actually provides a very wide neck or a huge neck that allows a clip to be placed, then perhaps that can be considered. Because sometimes after coiling of the aneurysm, and if it recurs, if there is still coils within the neck of the aneurysm, that actually can complicate clipping, and that would actually make clipping more difficult. So for those cases, you probably try endovascular, so stent-assisted coiling and things like that. But if there is if the recurrence is actually large enough that to accommodate clip, then those can be clipped quite safely.
Okay, thank you. The next question would be regarding the trapping of giant aneurysms. You have done a bypass surgery, and do you always trap the aneurysm, or just a proximal clipping or ligation would suffice? When do you choose to just ligate, and when do you choose to trap the aneurysm? That is, ligate proximally as well as put a clip in the distal ICA.
Yeah, so generally I would for cavernous aneurysms, I think it's probably safer to clip on both ends to prevent any flow into the aneurysm. But for some cases where, for example, there's a giant MCA aneurysm, and there are still important perforators arising in the vicinity of aneurysm. Those cases sometimes you would want to just do a proximal clip and reverse the flow, because the flow reversal actually still perfuses the perforators coming near the neck of the aneurysms. So for those cases, probably a proximal clip with a flow reversal strategy might be better. But for cavernous aneurysm, there are no perforators surrounding the aneurysm. So for those cases, probably to be sure, trapping may be a better strategy.
Okay. My last question before I hand it over to the the other viewers is your final comment. I know each aneurysm needs to be individualized. So what is your suggestion? Would a junior, you should learn both together, or each coiling should be one? Somebody should specialize only in endovascular technique, and somebody should specialize only in microvascular techniques. Because do you think a single person can have mastery over both microvascular techniques as well as endovascular techniques?
Yeah, I think in a high volume center and a very specialized unit, it's possible to gain mastery in both, and that's probably ideal because then you are impartial in terms of what to choose for the patient, because either way you are the treating doctor, and you probably know the best methods for each particular techniques. However, if there is no high volume, if you're not in a high volume center, probably working in a MDT setting is also a good option. However, it really has to be individualized. So basically, every patient, you probably have to have a very good working relationship with your endovascular counterpart, to really sit down and have an open discussion about what is the best for the patient.
Thank you, Professor Cheong. I have just one question from the chat box. Professor Mathuria from India, he's asked a question about are there any devices, endovascular devices, without which do not require dual antiplatelets?
Yeah, so the antiplatelets are generally for those that if you have to put a device into the parent artery, like the stents and all that. Intrasaccular devices generally do not need antiplatelet therapy. For example, the web device, contour device, these are the new devices that essentially are made for wide neck aneurysms and are purely intrasaccular. The limitation for those, if the neck is completely open, which means it's completely, open, those devices don't work as well. So for any devices that you put in the parent artery, antiplatelets will probably be required. There is a new study now that showed that stents with coating, HPC coating in particular, most patients can get away with single antiplatelet. However, there's currently the evidence is only for one particular type of coating, which is the HPC coating. So yes, there is, but quite limited for now.
Thank you, Professor Cheong. And my co-chair, Professor Florian, do you have any questions?
Yes, yes, I would do have some question. Professor Cheong, I really enjoyed the lecture and your philosophy on these techniques. I have two questions, provocative. As we have a global audience, do you take access to healthcare into consideration? We know that coiling requires frequent follow-up and
Yeah.
even do antiplatelet medication. Some patients can't even afford that. So is this
Mm.
something you put into consideration when you choose? I mean, some aneurysm you don't have a choice, but those where you have both options.
Yeah. So like I said, I think the aneurysm treatment should be individualized. While I mentioned patient factors and regional factors, but again, what you mentioned, the economical factors, healthcare access factors, local expertise factors, they all take into account as well, which is why no two aneurysms are alike. So for the same patient, one who is living in a country with very good healthcare access, perhaps you have probably more options to treat the patient. But I think essentially what best works for a particular patient in a particular location and particular local expertise will probably be the best option. So therefore, I think in the end there should not be any guidelines or dogma or rules to say that this sort of aneurysm must be treated with surgery, must be treated with coiling. End of the day, they are all just options, and really it should be suited with a particular situation. I think in my practice, because we do treat some patients from overseas, for example. So some of them, they are tourists in the country, and if they has a ruptured aneurysm, and generally if we know that they will be returning to a country with very minimal follow-up, sometimes if both clipping and endovascular options are equal, I'll probably lean more towards clipping rather than endovascular. So that's
Yeah,
definitely a consideration.
which is a very ethical approach, right? Because
Yeah.
you have to give him a chance for a continuous healthy
Yeah.
lifestyle.
Yeah.
So my second last question is, yeah, I mean, you're painting this ideal scenario, right? High volume center, everybody's hybrid trained, and then you have this non-biased decision making. Now, when I started training, everything was clipping, so I have my baseline skills. Now, how do you see in terms of training the younger generation where, I mean, the easy aneurysms are all going to coiling, the complex ones remain, and then so you train more numbers of vascular neurosurgeons than in the past. So the few remaining complex ones are even distributed among more colleagues. So everybody has significant less access to a volume of cases to get the skills. So how do you see this training in the future that, in 10 or 20 years from now, a young neurosurgeon is able to do this beautiful complex surgeries like you demonstrate in your videos?
So I think it is two different things. So microsurgical skills are most of the time translatable. While the clipping cases are dropping, there are other microsurgical vascular cases that are not dropping. For example, for in Asia, especially for moya disease, STMCA bypass. So the caseload for those are constant, and that's really a good platform to build microsurgical skills. Carotid revascularization, carotid stenosis, carotid endarterectomies, they are all good platform to build microsurgical skills. And the other part of aneurysm treatment is knowing anatomy, and also but that can be learned from a textbook, talking to people, and through experience and observing surgery. So I feel that sometimes some of the skills can be translatable. So for example, in endovascular, you don't really need to do a lot of a complex aneurysm, but there is stroke work which is quite numerous. So the basic skills can be trained via this kind of work. For example, EVTs and carotid stentings and things like that. So there are basic procedures that are there to train skills. And the rest is just really experience and learning anatomy and different approaches and techniques.
Great. Thank you. Thank you very much, Professor Cheong.
Mr. Chong, there are two questions from the chat box. One is, if it is a single antiplatelet, how long do you give? And second is, in cases where you have an equipoise where you feel both surgery and endovascular is equivalent, do you give the choice to the patient to decide?
Usually if there's an equipoise, then in Singapore at least, because there is access to both surgery and endovascular, and generally the healthcare insurance is not prohibitive. So then we would actually give the patient a choice if it's totally if it's really equipoised. But if there is one that is slightly better than the other, we will still give the patient a choice, but we will explain why one is better than the other.
And a
As
single
for
platelet for how long? The second question.
Yeah. So it really depends on what sort of devices. Generally, with any stents, it will be single antiplatelet aspirin for life usually. But the dual antiplatelet usually we stop after 3 to 6 months.
Thank you, Professor Cheong. And Ben, did we overshoot our time?
Yes. Can I ask final questions and then Professor Zhang, and thank you so much for your great lecture. And I can see the Singapore team and also see some familiar faces like Julian in your team. And then really congratulate your team on this management of this complex case. And I have two quick questions. The first question is about I learned from Ali Chris that there is one consideration is the microembolization as described in the literature for the endovascular cases, including, or they didn't specialize which type, the coiling or standing, but it's reported that the microembolization after operation up to 70 to 90%, whereas in the clipping cases and is in the around 40%. So in your experience, do you have any studies, or will you also tell the patient about this? And my second question as well, in the case of you have the case with the high flow bypass and also double barrel bypass, and what is the road of the double barrel bypass? Because I learned that from Professor Tanikawa that the double barrel bypass is mainly for the protective reasons. If for the flow itself, usually the high flow bypass is enough, but the role for the double barrel bypass is probably is a protective bypass versus the flow augmentation, because the high flow itself should suffice for the perfusion. Thank you so much.
Yeah. So with regards to your second question, I think um, I don't really have much experience in that sense, because cases like this where you are trying to replace the entire hemisphere plus the other one, because that particular patient has a contralateral ICA occlusion as well. So I think for the regular cases, if you're just replacing one hemisphere, definitely the high flow bypass is more enough. But that particular case, it was my first time where I'm treating a patient where after trapping the IC, I'm essentially giving him a bilateral IC occlusion. So for that particular case, I actually made the decision to perform double barrel bypass and also the high flow bypass. The idea was for the double barrel to supply the MCA branches, and hopefully the high flow portion, because I join it more proximally the M2, that would reflux more and actually perfuse the contralateral ACA territory plus the proximal M1 on the contralateral side as well. Yeah, so that was my thinking through the case. Obviously, this is a very, very rare situation, and probably will be difficult to find evidence to support what I'm doing. But sometimes, when we get cases, we don't often get textbook cases. Yeah. Yeah. With regards to the other question
About the
about the
microembolization.
microemboli, yeah. So generally we don't look for it, because to look for it, you probably have to do MRI for all patients. Um, and generally, if they are asymptomatic, then you wouldn't really do an MRI. For those that actually suffer from DCI and then you do an MRI after, I I haven't really seen much microemboli. I don't know of any evidence to show that this microemboli is really a big problem for the treatment of aneurysm. For carotid stents, that is quite apparent. So for carotid stents, um, comparing endodectomy versus stenting, definitely the presence of microemboli in the carotid stenting group is very well documented. But I'm not aware of any of this evidence in the aneurysm patients.
I see. Thank you so much. So,
Yeah,
Professor Rosa, do you have any comment?
yes, please. Without further ado, we want to move on to the second lecture. And ultimately, I believe our patients care about two things, right? In neurovascular, did the aneurysm get completely excluded? That's always the question. And how fast can they return to their lives? So modern management of intracranial aneurysms, minimizing the surgical corridor, and while maximizing the exposure safety remains a critical objective. So to give us a definite look at these clinical realities, it's my privilege to introduce Professor Gan Chao from the Department of Neurosurgery at Tongji Hospital in China. I'm looking very much forward to your lecture on the application of keyhole surgery for anterior circulating aneurysms. Please, Dr. Chao, go ahead. You can share your screen.
Thank you, host Rosa. Distinguished host, esteemed professor, and online colleagues, good evening. As a young neurosurgeon, it's truly a rare privilege to have the opportunity to exchange ideas with peers from all over the world. I really need to thank Professor Xubing for inviting me to share this topic. My name is Gan Chao from Tongji Hospital in Wuhan, China. Today, my topic is the application of keyhole surgery for anterior circulation aneurysm. The emergence and evolution of each surgical approach affected by the era and built upon the continuous accumulation of our predecessors. For example, for the frontal-temporal approach originated in the 1910s, was introduced by Professor Dandy and was applied to clip aneurysm at that time. Anterior approach originated in the 1960s is one of the most popular approach nowadays, and both lateral supraorbital approach and mini posterior approach are modified from this posterior approach. For supraorbital keyhole approach is summarized and popularized by Panetsky. I think he may also get some inspiration from extended lateral approach, so it's crucial to understand and learn from history. For classical posterior approach, as the most classical and very used approach is intensively applying tumor and aneurysm surgeries. And nowadays is centered around the keyhole and the sphenoid ridge. It provides excellent exposure for the frontal and temporal lobe. And nowadays we also do some modification for a smaller posterior approach. For the lateral supraorbital approach is another very important modified approach. It's proposed and popularized by Professor Yuha in 2000. It is centered on the lateral orbital ring, and the posterior ball window is shifted medially. And the exposure is achieved by elevating the lateral aspect of the frontal lobe. For the keyhole neurosurgery, which is popularized by Panetsky in the 1990s, one of the biggest difference between these two approaches is surgical feed. Keyhole approach visualize every aspect of the deep field through angle adjustment, which looks like a reverse funnel shaped. Of course, the concept of keyhole surgery is not merely to restrict the size of the craniotomy to a literal keyhole. Rather, it aims to achieve the minimal craniotomy ultimately required to access deep CT region. So the common use keyhole approach include supraorbital eyebrow keyhole, mini posterior keyhole, and interhemispheric keyhole. So for different anterior circulation and reason, a different approach section is tailored. For the eyebrow keyhole, I think the most is most used for anterior communicating aneurysm and post-communicating aneurysm, also including anterior choroidal artery aneurysm. Sometimes middle cerebral aneurysm can also be done in this way. For the mini-posterior approach, keyhole, the most used for aneurysm is middle cerebral aneurysm, and for in the hemispheric keyhole, the distal A2 to A5 aneurysm will be preferred. Another big difference for keyhole is little room for error. The surgical approach requires rough preoperative assessment, as there is limited space for intraoperative adjustment. At the very beginning, we use 3D reconstruction from CTA or DSA to inspect the direction, location of the aneurysm. We also measure the distance of the aneurysm projecting to the surface of the skin. 3D printer technique is also applied to imitate surgical procedure. Every primary surgeon needs to personally review the 3D reconstruction image and examine every detail. And the technical challenges and key points for keyhole approach are as follows. Firstly, narrow surgical field and limited working space. The surgical corridor is deep and spatially restricted. The microscopic field of view is limited, leading to inadequate exposure of the surrounding structure, which increases the risk of injury adjacent to neurovascular structures. Secondly, difficult proximal control during intraoperative aneurysm rupture. Once intraoperative aneurysm rupture occurs, the restricted space makes it difficult to rapidly apply temporary proximal occlusion. Achieving hemostasis is extremely challenging and carries a high risk. Third, raised variant lead to inadequate exposure. When cerebral spinal fluid release is inadequate or brain compliance is poor, the brain tissue bounces through the bone window. This prevents the exposure of deep structure or for the surgery to cannot go forward. The fourth, high technique demand. It requires long-term training to master microsurgical technique in restricted spaces. Sometimes endoscopic skills and emergency management capability are needed. So for beginner, it needs a long learning curve. Here is our continuous series of keyhole cases. Our team is led by Professor Gan Chao, and we carry out this work from 2023. From there on, aneurysm clipping, including 225, in which keyhole surgery was 126. For rupture intracerebral aneurysm, only 2 were clipped by keyhole surgery, and most cases is middle cerebral aneurysm, including 86. Also include some anterior communicating aneurysm and posterior communicating aneurysm. And other A1 origin or A2 distal are several cases. For this continuous series, the complication is not too much. 1 suffered subdural infusion, and 3 suffered perforating artery infunction, and 3 suffered facial nerve and supraorbital nerve injury. For post-operation, MIS greater than 1 has 2 patients. For the other 124 patients with MIS 0, this is without the death is 0. Nothing happens overnight, so everything has its learning curve. Here's our very beginning cases. We try this work step by step. This is a right middle cerebral aneurysm. We do a posterior approach, but during the subdural procedure, we strictly follow the keyhole procedure. After opening the lateral feature, this aneurysm is exposed at the center of our view. We can see the middle cerebral aneurysm is not very deep, and we can see it directly on our at the center of the field. After more and more experience and confidence accumulation, finally we transit to keyhole surgery. This is our learning curve and experience. Here is a A3 aneurysm with focal dilation. We do an interhemispheric approach. It has a local dilation. Yeah. Then we see the aneurysm. We use a standard curve clip to reconstruct the artery. We do some modification to reshape the artery. The intraoperative ICG indicates the aneurysm is clipped completely and the parent artery is patent. For supraorbital eyebrow keyhole, here we see several cases. This is very standard post-communicating aneurysm. After release of cerebral spinal fluid, the brain shrinks and we elevated the frontal lobe and opened the suprachoroid space. After open the space, then the aneurysm will directly appear at the center of our visual field. For every aneurysm, proximal control need to be under consideration. After separate the neck of the aneurysm, then we use a straight clip to close the aneurysm. The intraoperative ICG proved everything goes okay. After surgery, we can see the aneurysm is just at the center of our field. Here is another one with eyebrow keyhole. It's also a post-communicating aneurysm. It's very important to control the pressure of the brain. Only when the brain shrinks down, then we can do the forward things. For post-communicating aneurysm, it's relatively easy to expose, but the difficulty is sometimes we cannot see the perforating branch at the back of the vessel. After proximal trapping obstruction, we do this clipping. Then we inspect the perforating artery. You see some small branch were clipped. Then we do a modification. Then it will be better. Then intra-operational ICG were done to confirm the patency of the perforating branch. All patients were discharged at the post-operational day 3. Here is another anterior communicating aneurysm. It's now dominant side approach. We adopted a contralateral supraorbital eyebrow approach. For the anterior aneurysm, the bow flap is a little more medially. Then we cut a little rectus stirrus to exposure the anterior artery complex. With before operational the reconstruction, then we know where the aneurysm located and how the both A2 go across. After fully separate the neck, we use a straight clip to close the aneurysm. ICG confer the patency of both A2 and the aneurysm clipped completely. We use a curved clip to clip the small neck. The residue neck. Here's the overview. Here is another anterior communicating reason with 3 lobulation. We also use the eyebrow keyhole approach. The section some rectal gyrus to exposure the A2 and the aneurysm complex. As we know, the aneurysm has 3 lobulation, so we need to check how they directed. Here 2 and 1 is just directed up. After a full understanding of the structure, we separate the neck completely and then use a straight clip parallel to the anterior communicating artery is used to finish this clipping. Both A2 are patency and perforating branch a protected wear. For mini posterior keyhole and the lateral feature keyhole, the bow flap for the mini posterior keyhole is a little larger than the lateral feature ones. Here are some here is a picture we summarize for our patient. The lateral feature has a diameter around 2.66 centimeter, and the mini posterior has a 3.3 centimeter. It has a much more bone removal at the anterior inferior direction. And for mini posterior approach, the bone removal needed to drain off the spheroid ridge much more. And for FK, the sphenoid ridge drain off is very limited. And for MPT, the subfrontal and lateral feature corridor are needed. The LFK only lateral feature corridor is needed. For MPT, beyond the middle cerebral aneurysm, it has a broader range of application. For some classical MCI aneurysm, FK is enough. For the classical MPT, the temporal muscle is always retracted inferior, and we do some modification. Also, our linear incision with a burr hole at the anterior sphenoid ridge. Then a bow flap was drained off. Therefore, the incision line is not over the superior temporal line. The muscle is incised parallel to the skin incision, and the muscle was dissected anterior and posterior. Then we use this approach to get rid of the aneurysm with different angle adjustment. Let's see several cases. Here is a patient suffered right middle cerebral aneurysm and the left anterior temporal aneurysm. Firstly, we do the right one because it has a flap here. It's easy to rupture. We open the rear feature in a sharp dissection. After open the severe feature, we can see the M3 middle cerebral artery, then then along this vessel, we can found the aneurysm. Sometimes the severe vein will affect our operational view. Then we will make a more dissection for the vein and change the dissection to the temporal side. After remove this severe vein, then we get much more surgical view for the aneurysm. Here is the blood. Then a straight clip was used to clip the aneurysm. There is some calcification at the neck. After clipping, we need to inspect the operational field and try to dissect the wall of the aneurysm. The ICG confer a complete occlusion of the aneurysm. After operation, we will hear the bone in this shape to after 3 months, the patient come back again for the left anterior temporal aneurysm. This time we use a mini posterior approach. We need much more bone remove anterior and inferior to reach the subfrontal corridor. After this, then we open the lateral feature in the anterior feature seat. The M3 artery will be a good reference for us to find the aneurysm. Once we found the aneurysm, then we will try to have a proximal control to separate the M1. We can see the anterior temporal artery originates from the neck of the aneurysm. So we clip with a straight clip. After first clip, we found the origin of the artery is narrowed. Then we inspected the neck again. It's better. It's better. We do a ICG to check the patency of the artery. It's a MPT approach for the aneurysm located at the origin of the A1 segment. As we know, the A1 aneurysm always located beside the vessel, so it's not easy to see the branch and the neck. But for MPT approach, it's a oblique angle. We can see the deep region in an oblique direction. Then it's easier to see the neck and the aneurysm. We found this small perforate artery is located at the tip of the aneurysm. At that time, we don't sure whether it's a passing artery or originated from the wall of the aneurysm. After ICG, then we see this artery is patent. For ruptured intracerebral aneurysm, we try very few, as this need much more attention. From the CTA, we can see the aneurysm is directed to the temporal lobe. So during dissect the feature, once we see the aneurysm, we should to dissect the M1 for proximal occlusion. Firstly, don't try to dissect the aneurysm wall. After proximal occlusion possible, we clean up the hematoma in the lateral feature. Then we see the M1 clearly, and the M2. The rupture site is towards the temporal lobe. We clip the neck, and then after clipping, we inspect the aneurysm dome. Suddenly, it broke. This is the post-operational CT and the CTA. Aneurysm is clipped completely. Also, we suffered 3 cases with post-operational infunction. Here is a severe case. Before surgery, you can see is a middle cerebral artery aneurysm. And the operational procedure is as normal. After exposure to the aneurysm, we see a small perforating branch is tightly attached to the aneurysm wall. It was sacrificed. And also, we can see a lot of calcification at the neck and the wall and the aneurysm. After inspection, no perforating branch was misclipped. And we finished this operation as normal. But post-operational day 1, patient suffer right side with muscle strength 1 or 2. Post-operational day 3, we do a CTA. We can see the main trunk is patent, but the DWI indicate infunction at the basal ganglia. After 3 months rehabilitation, the patient recovered with the muscle strength around 4, can work with others' help. Here is another complex post-communicating aneurysm treated by mini-bacteria approach. These are large wide-necked post-communicating aneurysm with fetal type post-communicating artery. We do in a hybrid operation room. Epidural clinodectomy or clinodectomy. After remove the tip of the optical structure, then the tip is removed. We use a subfrontal corridor to further drain the cerebrospinal fluid. Then split the severe feature with rough dissection. Sometimes some small vein is need to be sacrificed in order to maximize the exposure of the aneurysm.
Dr. Gan, in the interest of time, do you mind coming to a conclusion? I'd love to see your videos, but we're running out of time.
Okay. Then after the operation, we see the pica and the anterior choroidal artery are perfectly protected, and the residue enlargement was observed as the pica origin, resembling an infundibulum, which will be inspected during follow-up. 9 months later, everything goes well. The DSA indicates the aneurysm is stable with no evidence of recurrence. Summarized, keyhole surgery is compatible to traditional clipping for unruptured anterior circulational aneurysm and can be a future direction for microsurgical development in the interventional era. Tailored keyhole approach should be adopted based on the specific location of the aneurysm, and always patient-centered. We adhere to standardized innovation and set rigorous learning curve, advancing step by step. Here's our team, and thank you for listening.
Thank you so very much, Dr. Gan, for these great cases you presented. I want to include the question from the chat into my question, and I have basically two questions. In the interest of time, let's go ahead. So number one is, you showed one case after rupture. So do you consider these approaches in general in ruptured aneurysms where we have angry brain swollen, or other way around, how you manage intra-op rupture if you have limited proximal control and limited angulation of your instruments?
Yeah, for this, for the ruptured aneurysm, we only try 2 cases, and during the procedure, we feel much more pressure and the danger. And once we don't handle the properly, it will be a very dangerous situation. So for rupture aneurysm, we normally use some suborbital lateral approach instead. And the most important thing for the rupture one is the proximal control is the first step. If you cannot have a proximal control, then don't touch the aneurysm. Once happened, then I think the section for the pinhole approach, I think you cannot get much help from others for the primary surgery, I think he needed quicker sector the site and then do a quick clipping for the rupture, then do much more modification.
Yeah,
Thank you.
that makes sense. Okay, thank you. So my last question is, so, and that's interesting for the global audience. So with this variety of cases you showed very nicely, but I would be interested because I personally had that experience. Did you remember any case where you really struggled and you made the wrong decision of the approach where you afterwards said, "Man, I should have done this different way." So did that influence your decision making in the future cases?
At the very beginning, yeah, I think it's confidence communication, experience communication. At first, I think we do keyhole surgery. I think the longest time is 5 hours, but right now maybe 2 hours is enough. And at that moment, I think, yeah, it's very struggle during that procedure for 5 hour surgery. But after you get over this difficult moment, then you will get much more confident. And then you think, yeah, you will be okay. And also you will learn much more from this experience.
Good. Okay. Thank you very much. And then
Thank
I
you.
want to hand over to the chairman, Ben.
Yes. So, are there any final questions on the forum? If not, I think it will come to the end of our ACNS webinars. So, and I would like to say the concluding remark for this ACNS webinar. And on behalf of the Educational Committee of the ACNS and the Professor Yoko Kato, I would like to thank both the speakers of today, Professor Tien and also Professor Gan Chao, as well as the chairs, Professor Joyce Menon and Professor Floria Rosa, for the time and support for the ACNS webinar. And a very special thanks to Professor Xu Bin for broadcasting this webinar on the WeChat channel. And today we have 680 views on the WeChat channel for this episode of the ACNS webinar. And special thanks to my cohort, Dr. Roger and also Dr. Liu Bun-Sing for joining me today. And also, last but not least, we have also launched our ACNS webinar app, which can be downloaded on both App Store and Google Play Store, and is already downloaded by more than 700 people in 81 countries. And with that, I would like to conclude the section, and I really, really thank you so much. And indeed, we have a very educational night for the aneurysm surgery. I know many is quite debatable topics, but I really thank you both of the speakers today and also our chair today for these excellent webinars. And thank you so much, and I hope to see you all in the future. Thank you so much.